معاكم دكتور هاني زحلاوي مدرس جراحة عظام جامعة عين شمس. هكلمكم النهارده عن السباينال fractures. Epidemiology of the spinal fracture. The incidence of spinal fracture is 6% of all the trauma patients. About half of these patients suffer from neurologic injury. There are concurrent injuries with spinal fractures. For example, in thoracic and lumbar fractures, they are associated chest and abdominal injuries, like pneumothorax, hemothorax, ruptured spleen. There are low incidence of abdominal injuries in the cervical spine. However, the spinal cord injury is much more common with fracture of the cervical spine. Common sites of fracture of the spine, they are concentrated in the junctional zones. We mean by junctional zones the thoracolumbar lesion, which is a junction between stable thoracic spine and mobile lumbar spine. This is where the stresses are concentrated, and therefore the spinal fractures are very common. The same with craniocervical junction and the cervico-thoracic junction. The spinal cord injury is much more common in young males with a male predominance of 4:1. Spinal cord injuries are common in middle-aged, 30 years old, and as I said, they are more common with cervical spine fractures. The causes could be divided into high energy trauma and low energy trauma. High energy trauma, the most common is motor vehicle accidents, falls from height, gunshot injuries, and sport injuries زي المصارعة. We mean by low energy trauma people who suffer from certain pathology in the spine, most commonly osteoporosis in the elderly. These people suffer from fractured spine from minimal trauma like falling from standing height. This is an example of sport injuries. This is an American football player. There is an infection with axial load to the head leading to burst fracture of the cervical spine. I would like to talk to you a little about the anatomy of the spinal cord. In C1, the spinal cord occupies about 35% of the canal. It involves about 50% in the lower cervical and thoracolumbar spine. As they occupy 50%, the incidence of spinal cord injury is higher in these segments. However, below L1, L2, the canal is occupied by the coda equina. The coda equina are the lumbosacral nerve roots. Therefore, with spinal fractures, neurological injury is much less common in below L1 because the nerve roots occupy much less in the canal. As we can see, the spinal cord here stops at L1, L2. Below L1, we can see the nerve roots or the coda equina. The termination of the spinal cord is called the conus medullaris. The conus medullaris is occupied by the sacral myelomeres. Sacral myelomeres are responsible mainly for bowel and bladder function. So people with fracture L1 may present with bowel and bladder dysfunction, what we call a conus medullaris syndrome. As I said, coda equina is much less likely to be injured because they occupy less volume in the canal, and as the coda equina are lower motor neuron lesions. So lower motor neuron lesions are much better in their prognosis than upper motor neuron lesions due to the spinal cord damage. Okay, so a care of traumatized patient, we have pre-hospital care at the site of the accident and emergency care in the hospital. For the pre-hospital care, it is very important for us to stabilize the head and neck and not to rotate the head and neck in relation to the trunk, and we should consider every patient as having a cervical spine fracture until proved otherwise. they should wear a cervical collar. This is a Philadelphia collar, and as you see, these cervical collars have a space anteriorly. This space is made so that if the patient has any disturbance in their airway, they could perform an urgent cricothyroidotomy or tracheostomy. If the patient with a motorbike accident is wearing a helmet, it is recommended that in the site of the accident, you shouldn't remove the helmet so as to avoid any neurological damage. In the emergency department, we should manage patients with fractured spine like any other patient with multiple trauma. We know the A, B, C, D. We should take care of the airway, breathing, circulation. We should address life-threatening injuries and maintain spine immobilization, as I said, using a cervical collar. And during transport, if we suspect a lumbosacral fracture, they should be on a rigid board. Okay. On examining a patient with suspected fractured spine, we should move the patient as one piece. This maneuver which we see on this picture is called log rolling maneuver. We see a person stabilizing the head and neck, and two other people crisscrossing their hands. And they turn the patient as one piece and look at the patient's back. What can we find? We should seek for tenderness, any bruises or contusion, and we should feel the spinous process. If there is any distraction injury in the spinous process, we would find a palpable gap. And we should also seek for chest and abdomen injuries. As I will tell you later, one of the fractured spine mechanisms is what we call a flexion distraction. This occurs when the patient is in a motor car accident wearing a seat belt. Severe flexion leads to distraction of the posterior elements of the spine, leading to a fracture like this. And it is very common that these patients come with abdominal injuries like ruptured spleen or torn mesenteries. Okay, so when we have a patient, polytraumatized patient in the emergency room, we should take a history from the witnesses, for example, if he was moving his extremities at the time of injury, if there's a history of head trauma, if there's any loss of consciousness, and for us we should perform a complete neurological examination. We should perform a motor examination, sensory examination, and see the reflexes. And it is very important for us to see the perianal sensation and the rectal tone. People with spinal fractures may suffer from three types of shocks. He may suffer from neurogenic shock, and that is due to disruption in the sympathetic chain in the upper cervical and the thoracic region. Disruption of the sympathetic chain leads to hypotension, but there would be no reflex tachycardia. There would be hypotension and bradycardia. If the patient suffers from hypovolemic shock due to bleeding, for example from ruptured spleen, there would be hypotension and reflex tachycardia. So it is very important to see the difference between the two types of shocks, as the treatment of hypovolemic shock is fluids resuscitation, while the treatment of neurogenic shock is dopamine or dobutamine injection. People with spinal cord injury suffer two types of injuries. The primary injury, which is compression, laceration, or sharing in the spinal cord, and secondary injury, which occurs later due to ischemia of the spinal cord This ischemia of the spinal cord leads to release of free radicals, arachidonic acid, and prostaglandins. These materials all lead to disruption of the membrane of the neural tissue of the spinal cord. So, some people advocate giving corticosteroids in high doses when a patient comes to the emergency room with spinal cord injury. So we give Solumedrol. We give by the dose of 30 milligram per kg as a loading dose, and as a maintenance we give 5.4 milligram per kg per hour. But in order for these steroids to have an effect on recovery of the spinal cord injury, the patient must come to the hospital within 8 hours of their injury. If he comes after 8 hours, there's no need to give steroids, as there is no improvement following steroid administration. Okay. There are two types of spinal cord injury. We have complete spinal cord injury and incomplete spinal cord injury. People with complete spinal cord injury have very poor prognosis. People with incomplete spinal cord injury have much better prognosis. What we mean by complete and incomplete? We search for what we call as sacral sparing. The sacral fibers in the spinal cord are most peripheral. So if the peripheral sacral fibers are intact, we call the spinal cord injury incomplete spinal cord injury. Clinically, we search for sacral sparing by looking at perianal sensation, rectal tone, and voluntary anal contraction. So it is very important to ask the patient and to examine the patient for sacral sparing to know the prognosis. So, what about motor examination? In motor examination, we choose key muscles in the upper limb and lower limb. The key muscle in the upper limb, for C5, we look at biceps, which is elbow flexion. C6, wrist extension. C7, elbow extension, triceps. C8, finger grip. T1, finger abduction. In the lower limb, the key muscles, we look at the iliopsoas muscle, L2, hip flexion, knee extension, quadriceps L3, tibialis anterior, ankle dorsiflexion, L4, extensor hallucis longus, toe extension, L5, and gastrosoleus or ankle plantar flexion, S1. We must look at all these muscles and record any injury. Okay, I would like to talk to you a little about thoracolumbar fractures. We have the vertebrae, the anterior element, the vertebral body, the posterior element, the neural arch. The first classification made divided the spine into anterior column, which is the vertebral body, and the posterior column, which is the neural arch. In the 1980s, Dennis divided the spine into anterior column, middle column, and the posterior column. Anterior column involves the anterior half of the vertebral body, middle column, the posterior half of the vertebral body, and the posterior column, the neural arch. According to Dennis' classification, he named 4 types of fractures: compression fracture, burst fracture, seatbelt fracture, and fracture dislocation. And according to Dennis' classification, if we have 2 out of 3 columns fractured, the fracture is unstable. and he stressed that the middle column is the most important column for the stability of the vertebrae. We mean by compression fracture in the anterior column only, while the middle and posterior column are intact. We mean by burst fracture in the middle column, and when the middle column is fractured, the posterior cortex of the vertebral body jumps backwards into the canal, forming what we call a retropulsate fragment. This retropulsate fragment can compress the spinal cord or the coda equina. Flexion distraction injuries, as we said it, which is equivalent to the seat belt injury leading to distraction in the posterior column. Fracture dislocations, which is the most severe type of thoracolumbar fracture, with associated high incidence of neurological damage. This is an example of fracture dislocation, shear force leading to translation of the vertebrae. Diagnostic studies, it is important for us to perform a plain X-ray, anteroposterior lateral view. In cervical, we add an open mouth view to assess the axis and the atlas. We can perform a CT to see the vertebral column combination and the retropulsate fragment. MRI gives us an idea about the ligaments, posterior ligaments. We should look at the interspinous ligaments, and we should search for any epidural hematomas and any damage to the cord. There is no role for electrodiagnostic testing. We don't perform EMG or nerve conduction test for any patient with acute spinal cord injury due to trauma. Treatment, the goal of a treatment is to protect the neural tissues, and if there is a neurological damage, to perform a decompression to relieve the neurological and reverse the neurological injury. The third aim is to prevent any deformity. A patient with unstable fracture may present with a late kyphosis, and to permit early ambulation and rehabilitation to prevent complications of prolonged immobilization like DVT, pneumonia, and bed sores. Non-operative treatment involves bed rest and postural reduction. If there is a compression fracture with loss of height in the anterior column, we let the patient sleep prone. The lordosis leads to reduction of the height, and we can cast the patient. Operative treatment involves placing of screws, pedicular screws or hooks with rods, and performance of decompression. We have two types of decompression. Direct decompression, which involves corpectomy, the removal of part of the vertebral body with the retropulsate fragment, and insertion of a bone graft, or as we see here, we insert a mesh cage filled with cancellous bone to perform anterior fusion. These are the pedicular screws. In cervical spine, we could perform conservative treatment in the form of halo traction and its conversion into halo vest, or we can perform anterior surgery, which involves corpectomy and insertion of a plate. Thank you.